Thank you, Barry. I appreciate the opportunity to speak on limbal stem cell transplantation, kind of give a historic overview where we are today and then where we may be going tomorrow. These are my financial disclosures. None relate to limbal stem cell failure or treatment of that. So the past is somewhat interesting, and actually the real start of ocular surface transplantation dates back to the World Cornea Congress in 1964. And actually, Jose Barraquer described a procedure in which he took conjunctiva and limbus from a normal eye of a unilateral chemical injury patient and transferred that, basically describing the present-day conjunctival limbal autograft that many of us do for unilateral injuries. And he had it in '64, but unfortunately, not a lot of follow-up in terms of ocular surface transplantation really occurred until Richard Thoft started talking about different procedures to be used for severe ocular surface injuries. And his paper in 1977 was really the next breakthrough in terms about how to address these patients. And he described a conjunctival transplantation, which is the conjunctival autograft procedure we now do now. And then follow-up papers in 1984 and 1990 on what he termed keratoepithelioplasty. His first paper described taking peripheral cornea. He didn't describe the limbus as a source of stem cells because in '84 we didn't know about the limbus. And then 1990, after that information was really understood, he incorporated limbal cells into his procedure, really the precursor to today's keratolimval allograft. And then it was really the breakthrough on the basic science of the limbus that really got us thinking about how to really come up with surgical procedures to deal with limbal deficiency. Work by Davinger and Evanson in the '70s, Shermer, Sun, and Kinoshita, and Potton in the '80s really led to the understanding of the function and pathophysiology of the limbus. And as I go through these historic papers, I apologize. I'm sure I'm going to forget key papers, but in the interest of time, I thought I'd point out some of the key ones. So the paper by Kenyon and Sang really got modern-day ocular surface transplant going. They basically described what Barraquer described in 1964, and that was taking conjunctiva and limbus in unilateral injuries and transferring it to the diseased eye, and they had excellent outcomes, and again, it's what's done today. Tsai and Sang then in cornea in 1984 described an allograft procedure in which they took whole globes and harvested peripheral cornea and limbus with this lamellar dissection, again, a precursor to the keratolimval allograft. Quitko described using a living relative as a source of ocular surface cells. He was doing a living-related conjunctival transplantation, so again, a precursor to what moved on to be the living-related conjunctival limbal allograft procedure, but the first to describe a relative as a source of ocular surface cells. We've tried to advance the field with some of the papers we've written. We talked about new techniques for keratolimval allograft in '96, but more importantly, really what eye banks needed to do. Eye banks were totally focused on the endothelium and really were not harvesting tissue and saving the limbus. In fact, they were taught to really take all the conjunctival limbal cells off. And so it was a whole change in the thinking of harvesting tissue to harvest tissue for both epithelial disease and endothelial disease, and today that is what is done. We had to really talk about nomenclature because there were multiple terms for the same procedure and a lot of confusion, and so we put forth a classification of the nomenclature in 1996. We talked about combining keratolimval tissue and living-related tissue for the worst patients with conjunctival and limbal disease, and so-called the Cincinnati procedure. And finally, we've really advocated for patients who have ocular surface transplants to be treated with systemic immunosuppression on organ transplant protocols. And this has been pretty a difficult path because most corneal surgeons are very reluctant to expose their patients to the proper immunosuppression, and unfortunately, it leads to high rejection rates and high failure rates. In fact, if you look at the evolution of immunosuppression, for a long time, it was prednisone only, and then it was kind of double drug prednisone and cyclosporin or tacrolimus. Finally, in the late '90s, we moved into triple drug therapy. But present day now, we realize it's really the tacrolimus and mycophenolate that are the important drugs, and we've moved on to prednisone sparing. We use very low-dose prednisone for very short periods of time, and often on the second eye in a patient who's chronically immunosuppressed, we use no prednisone whatsoever, really reducing our side effects significantly. So as this whole evolution of tissue transplant was going on, there was then the evolution of cultured limbal epithelial cells, or the so-called CLET procedures. And again, interesting papers and progress in this field. So studies on cell culture led to the concept that you could culture epithelium and then potentially transplant that to the ocular surface. And Pellegrini's landmark paper in The Lancet in 1997 described autologous cultivated corneal epithelium applied to the ocular surface of a unilateral chemical injury patient. There was papers by Schwab looking at allogeneic cultured stem cells, and Tsai, again, published a similar technique in which they used the amniotic membrane as a carrier for cultured cells. Nishida and Kinoshita talked about using cultured oral mucosa, the so-called COMET procedure, as a way of dealing with ocular surface disease. Shiraz Daya then talked about using cadaver donors, but not transplanting that corneal scleral rim that a lot of us do, but using cultured cells from the cadaver donor in those patients that didn't have a living relative to be the donor, and that was described, his technique, in 2007. So in these CLET procedures, we have an ex vivo culture technique. You can take cells from the own patient, whether it's going to be the contralateral eye or it's going to be oral mucosa, or you can take allogeneic grafts, whether it's going to be a living relative, a cadaver procedure. You can use an explant culture technique or suspension technique, and these techniques continue to evolve. Where are we today in 2015 in limbal stem cell transplantation? First of all, in the tissue techniques, we have the conjunctival limbal autograft, which is the same procedure that was described in 1964. We have the living-related conjunctival limbal allograft procedure, and then the keratoid limbal allograft procedure. And there's obviously advantages and disadvantages to both. For unilateral disease, we certainly look to the conjunctival limbal autograft as a procedure of choice. It eliminates our biggest problem in tissue grafts for the ocular surface. It eliminates rejection. You need to have a normal fellow eye, and you certainly wouldn't want to risk taking limbal cells if there's a partial injury to that fellow eye. And again, you only have one choice to go to that fellow eye, so you want to make it at a time when it's most reliable. And this is the first one I did back in the early 90s. This is a unilateral chemical injury with a persistent epithelial defect. And you can see on the post-op graph the quiet autograft conjunctiva, but yet the inflamed disease conjunctiva stayed inflamed for many, many years. This gentleman has done well long-term with his conjunctival limbal autograft. But our biggest challenge is the bilateral patients, and we look to either cadaver donors or living-related donors. Now, the cadaver donor definitely has advantages. It's one procedure. It doesn't involve finding a relative and going through that discussion with the relative, and we get a large number of stem cells. But obviously, we can't tissue type. We do have an increased risk of rejection, and unlike the living-related procedure, we don't get good conjunctiva. So if the patient has conjunctival disease with limbal disease, this doesn't work as well. These are some of the early cases I did back in the 90s. Again, these are bilateral alkali injuries, preoperatively severe corneal scarring, neovascularization, status post-keratoid limbal allograft, and then 3 months later, they're penetrating keratoplasties. Both these patients had vision for a long, long time with that procedure. This was a patient who had variant aniridia, and she developed total limbal deficiency in both eyes down to count fingers vision. She has undergone keratoid limbal allograft, and you can see over time the keratoid limbal tissue fades. You can see the edge of the keratoid limbal tissue here. She's 12 years out, has had 2 children, off immunosuppression, and excellent visual acuity. What about the living-related conjunctival limbal allograft procedure, and why would we do that? Well, we get conjunctival cells. We get conjunctival goblet cells and epithelial cells, so it addresses conjunctival disease. We can HLA match these patients, and if you're lucky enough, you can get a very good HLA match and drastically reduce your risk of rejection and your exposure to immunosuppression. But it does take 2 procedures. There is a theoretical risk to the donor. I've done many of these procedures, and I've never had a problem with the donor, but that is a discussion that's sometimes difficult to have. But you do not supply a large amount of stem cells as you do with the keratoid limbal allograft procedure. This is a patient sent to me from New York who's a bilateral long-term contact lens wearer, and you can see in 2007 she was having progressive conjunctivalization of her surface. It moved across the visual axis, went 360 degrees in both eyes. She went down to 2400 vision. Here she is now 6 years out. You can see excellent epithelium. You really can't even see where we did the living-related conjunctival limbal allograft. She had 9 siblings, and she had 2 siblings that are identical HLA matches. and we used one of those siblings for each eye, and then she's done great off immunosuppression. We described the Cincinnati procedure because if you can see this eye with its extensive conjunctival disease, if we do just a keratolimbar procedure, we wouldn't get conjunctiva. And we found when we did the living-related conjunctival limbal allograft procedures that it would fail at 3 and 9 o'clock. So we combined these techniques for our worst patients. And this is a gentleman with a chemical injury. He had multiple amniotic membrane transplants and 4 keratoplasties, all failed. And he was one of the first cases we decided to do this procedure on. We're going to recess the scarred conjunctiva back. We never want to resect this tissue. We want to save this tissue. It often recesses back and forms actually the palpebral surface, conjunctival surface of the lid. So this is the living-related tissue, and you can see at 12 o'clock you get quite a large piece of conjunctiva from that donor that really addresses the conjunctival deficiencies. You get goblet cells, good conjunctival epithelium, and that's extremely important in these eyes. 3 months later, we do a penetrating keratoplasty in this eye to get his optical rehabilitation. And he was on tacrolimus and mycophenolate for many, many years. He recently was discontinued off his mycophenolate and has done extremely well. So today, what can we get with our surgical procedures? Well, we can get good outcomes. We described a series of 258 eyes, and 125 of these eyes had conjunctival disease as well as limbal disease. And we have a stable ocular surface at about 72%. Pre-op visual acuity was count fingers, post-op mean visual acuity was 2,300, but it included a large number of anaritic patients who have a visual potential of the 2,100 to 2,400 because of retinal hypoplasia. We've shown that immunosuppression is safe in these group of patients, and we looked at a retrospective analysis of over 10 years in our patients undergoing ocular surface transplant. We had 136 patients, 225 eyes. The mean follow-up was 4.5 years. We had patients are healthier. They're different than the organ transplant patients who have diabetes and hypertension and get side effect complications. Our mean full immunosuppression was 3.5 years in these patients before they were transferred to monotherapy with CellCept. Again, in this series, about 77% with a stable ocular surface, and 35% were completely tapered off immunosuppression. And the majority that were still on immunosuppression were only on monotherapy with CellCept. Unlike big series in organ transplantation, we had no deaths, we had no secondary tumors. We did have 3 severe events, 3 AEs, MI and pulmonary embolus, but again, no deaths. And we had several minor incidents such as renal and liver changes in function, but all responded well to tapering the medication. So immunosuppression is safe. We individualize the immunosuppression based on the patient. So if we have a living relative with an identical HLA match and the patient's never had previous surgery, we can use a lot less immunosuppression than if the patient's had multiple corneal transplants and we have a cadaveric donor, and that patient's going to be sensitized and we'll use a much greater degree. So all the patients don't get the same immunosuppression, and this is exactly what is done in organ transplantation. And we follow the organ transplant protocol that is done for organ transplantation at the University of Cincinnati. And if I think of the one single thing that I think is an obstacle to successful protocols, is not the surgery. The surgery is not the challenge. It's that most corneal surgeons won't embrace the systemic immunosuppression. So, I mean, you wouldn't see a kidney transplant surgeon doing a kidney transplant and then putting a patient on CellCept for 6 months and expecting that patient to do well, but yet we continue to see that. So, again, I can strongly advocate, we've learned from organ transplantation what works, we should follow it. We also heard that these patients don't do well. They don't keep vision beyond a couple years, and so we looked at a group of patients just the last few months that we had 5 years of successful ocular surface transplant, and what was unique about them. So we had a mean follow-up of 9 years in these patients. We have 110 patients and 165 eyes. Again, rejection was the most common cause of ocular surface failure. In fact, our rejection rates are higher than kidney transplant rejection rates for some reason, which is very surprising to, I think, transplant immunologists. So 25% of rejections led to total surface failure, 11 led to partial failure, but 63% of these rejection reactions we were able to reverse with change in immunosuppression. We did in this long-term group of patients get ocular surface stability in 73%. Visual acuity was improved in 62% of 2 lines or more. We have 53 eyes with 10 years more follow-up, and again, 60% have maintained a stable surface without other intervention. And what is unique about this survival group is that we do get patients off immunosuppression, but in going through their charts, compliance really separated these patients from the failures. 93% were absolutely compliant with all the post-op visits, with all the systemic medication protocols, and I think that's absolutely key to the long-term outcome. What about outcomes of cultured limbal epithelial cells? And we looked in the literature of studies that were 2 years or more in duration, and there were over 1,300 eyes in these studies. They're a little bit confusing because many of the studies mix autografts and allografts, so it's a little bit hard to get the outcomes of just the allografts alone. By far, cultured limbal epithelial transplantation has done for chemical injury 84% of the patients in these trials. The limitations in terms of defining success, they weren't really clear in a lot of the papers how they define success, but according to the authors, the overall success rate in these pooled 9 studies was 62%, and 63% had 2 lines of improvement in visual acuity, so somewhat close to what we're getting in the tissue techniques. There really was no consensus on immunosuppression in these CLET procedures. It ranged from no systemic immunosuppression to most commonly monotherapy with tacrolimus or cyclosporin or mycophenolate. Some authors did adopt the organ transplant protocols. One study looked at rejection only in CLET, and they found in these 42 eyes that 30% of the failures were due to rejection, again, the most common cause of rejection. Advantages, it looks like, to CLET is that obviously a smaller amount of donor cells, so if you're using a living relative, this is certainly advantages. More possible using autologous cells, so if a patient has a partial injury, you may be able to use the same eye to get tissue. And it looks like, based on the outcomes, that less immunosuppression will be needed. But certainly disadvantages, we have a lot more cost. We need a good tissue culture facility, which is, again, difficult and expensive. And these procedures really don't supply any conjunctiva, which, again, is our biggest challenge. So where are we going in the future? A couple interesting things. We have the work done by Griffith and Fagerholm looking at the biosynthetic cornea, in which they're growing epithelium, stroma, and endothelium in the laboratory and transplanting these in patients. And potentially this could be used to address ocular surface transplantation. And again, they have very interesting data looking at the morphology of the epithelium, the corneal nerves, the keratocytes, and the endothelium, and it certainly looks normal, and these corneas are functioning. But where do we need to go? A few things that certainly I would like to see tackled the next decade of ocular surface transplantation. Definitely breakthroughs in immunosuppression. We're using different protocols that's safer, but obviously we can reduce the side effects even more. It would be great to somehow manage the tissue to make it non-antigenic, and culture techniques show that you reduce antigenicity when you have cells in culture. We really need conjunctival replacement. We need cultured conjunctiva to deal with the severe ankyloblepharon patients that we have, and ex vivo expansion will probably be the answer. But in that realm, we need this to be more affordable because it is certainly very, very expensive. And again, I think the final kind of solution to all this will be patient-derived bone marrow cells taken from the recipient patient themselves, cultured. These will be obviously non-anergetic, they won't be able to reject, and will be potentially the best source for ocular surface transplantation. I thank you for your attention.